Good morning, ladies and gentlemen. We'll start this session, Oncology 9, on colorectal carcinoma.
In the interest of flow, we have swapped the next two speakers. So Dr. Elizabeth Bernard will be speaking next. She is a nuclear medicine physician from Royal North Shore Hospital in Sydney, and Dr. Bernard will be talking on regional treatment with yttrium-90 SIR-spheres.
Thank you very much, Eva, and thank you very much to the organising committee for inviting me to talk on this topic today. The objectives of this presentation are for us to understand the scientific concepts which underpin radioembolisation with Y90 SIR-spheres, and to review the clinical and technical aspects of delivering regional treatment with Y90 SIR-spheres. We'll then have a look at how this is applied in patients with colorectal cancer. Now, SIRT, selective internal radiation therapy, is a local regional treatment of liver tumours achieved by the intra-arterial infusion of radioactive microspheres. These microspheres are biocompatible resin measuring between 20 and 60 micrometres in diameter, which are trapped by the small capillary vessels of tumour. These are labelled with yttrium-90, which is a pure beta emitter with a 64-hour half-life and a beta emission maximum range in tissue of just 11 millimetres. Radiation is deposited over a 3-week period. The particle size is small, and this gives little embolisation effect, and the therapeutic effect of this treatment relates to radiation delivery rather than embolisation. SIR-spheres are infused directly into the hepatic arterial circulation via a catheter placed in the femoral artery. SIRT takes advantage of the dual blood supply of the liver. Normal liver parenchyma receives the majority of its blood supply via the portal vein, whereas metastatic and primary liver tumours receive the majority of blood supply via the hepatic artery. Now, a catheter, once placed in the hepatic artery tree, allows us to deliver SIR-spheres close to the liver tumours. In an ideal situation, the hypervascularity of a tumour deposit draws the SIR-spheres to it, and there is relatively less delivery to the nearby normal liver compartment. This therefore allows us to deliver a tumouricidal dose of beta radiation to the liver tumours whilst maintaining a low and non-damaging dose to the normal liver tissue. Now, it's not uncommon for there to be side vessels off the hepatic arterial tree that supply upper abdominal viscera, and it's important for us to avoid irradiation of other extrahepatic non-tumour tissues. Now, SIRT is safe and effective when SIR-spheres are delivered with the right intent to the right location in the right dose for the individual patient. And achieving this is dependent on a very individualised approach to each patient. At North Shore, the delivery of SIR-spheres therapy is a close collaboration between nuclear medicine and interventional radiology and involves several steps. Firstly, a thorough clinical assessment of the patient, then an imaging workup consisting of a planning angiogram and MAA study, an individualised treatment plan and dose prescription for each patient, and then the treatment delivery. Following treatment, we will image where the SIR-spheres have gone with Y90 PET-CT or Bremsstrahlung imaging on a gamma camera, and then do follow-up imaging ideally to assess treatment response. Now, patients are referred to nuclear medicine by a multidisciplinary team or tumour board, and these patients will be ones with liver-only or liver-dominant metastatic disease or primary disease of the liver. The possibility of surgical resection of metastases will have been excluded. As Professor Harriet pointed out, this is very important now in the treatment process. Local ablative therapeutic options will also be considered at the MDT in consultation with the interventional radiology team and radiotherapy to determine which is the most appropriate local ablative therapy to use. Once decided that SIRT is the appropriate therapy, they'll be referred on to nuclear medicine. Ideally, these patients will have a reasonable life expectancy and adequate general clinical condition and preserved liver function. It is then up to us to establish that the risks of treatment are acceptably low and the likelihood of benefit for the patient is sufficiently high to proceed. And this is because SIRT is not without risk. Assessment of this risk-benefit ratio in each patient needs a good understanding of the risks of SIRT and the clinical features which signal increased risk. An important complication is REALD, radioembolization-induced liver disease. It results from irradiation of the normal liver compartment. It's a rare complication, but a very significant one. It typically occurs 4 to 8 weeks following SIRT and is typified by hepatomegaly, jaundice and ascites. The risk is higher in patients with impaired hepatic functional reserve and also in patients who receive a higher radiation dose to the normal liver compartment. The following is a list of risk factors for RE-ILD. If there is extensive tumour infiltration in liver, you have a reduced amount of non-tumour liver and a higher risk of REALD. Paradoxically, patients with a low tumour volume also have a higher risk of this because the majority of dose is going to non-tumour. Patients having whole liver treatments with no spared segments are at higher risk. Patients with small liver volumes, perhaps having prior partial hepatectomy or resection, and patients with cirrhosis are at higher risk. And where the relative uptake of surspheres in tumour compared to non-tumour is low. We also need to consider the prior insults that the liver has received, as this will affect the functional status of the normal liver and increase risk of RE-ILD. There's increased risk associated with patients being exposed to a significant amount of prior chemotherapy, which in colorectal patients is very common, and this is defined as 2 or more lines of chemotherapy. Patients who've had prior liver-directed therapies with TACE or SBRT are at higher risk, and also patients with other liver conditions, most importantly cirrhosis. In the clinical workup, it's very important to look at the liver function tests and trends in liver function tests. Bilirubin, albumin and transaminases reflect most strongly the hepatic functional reserve, and we have a few cut-offs for treatment. Treatment is contraindicated if bilirubin is over 34 micromoles per litre. If patients have risk factors for RE-ILD, it should be less than 25, and in a cirrhotic patient, we've got less room to move and it should be less than 21. Albumin should be within normal limits and transaminases not significantly elevated. The second major set of complications relates to the inadvertent irradiation of upper abdominal viscera from the delivery of surspheres to them. If surspheres are delivered to the gastrointestinal tract, the stomach or the duodenum, you can get local radiation damage with ulceration and potentially perforation. All patients are put on proton pump inhibitors to reduce that risk. If there's delivery to the pancreas, pancreatitis may occur, the gallbladder, cholecystitis, and importantly, necrosis of the gallbladder and perforation. And if there could also be delivery to the lungs via an excessive liver-lung shunt. So our workup needs to exclude the possibility of these things occurring. A couple of drug interactions are also important to be aware of. Patients who are on anti-angiogenesis therapy should have that withheld for 4 weeks before and after treatment. And this is because drugs like Avastin compromise the morphology and the patency of hepatic arteries and affect the vascular supply to tumour and non-tumour. Tyrosine kinase inhibitors should be withheld for a period before and after, 2 weeks before and after, because these are associated with reduced hepatic regeneration following the radiation insult. Gemcitabine, importantly, is an antimetabolite, which needs to be withheld for 8 weeks prior to treatment. A couple of prior surgical procedures are also important to be aware of. If someone's had a Whipple's procedure, there will be altered vascular anatomy and integrity of the biliary tree, which increases the risk of biliary infection related to any degree of ischemia from the surspheres therapy. And these patients should be put on antibiotic prophylaxis. We also need to understand if patients have had prior liver resection, partial hepatectomy or metastatectomy, so that we can adjust for this in the administered dose prescription. Lastly, portal vein thrombosis is another important thing for us to be aware of. This is not a contraindication for SERT treatment, but it may result in a greater recruitment of the hepatic arterial system to supply the blood to the normal liver. We need to look closely at the dosimetry, what the normal liver is receiving, and because there's a higher rate of toxicity from this increased delivery to normal liver. Now, having done that clinical assessment, we move on to the imaging workup, and this involves the planning angiogram and the MAA study. The planning angiogram is for vessel mapping. The interventional radiologists go in and map the hepatic vascular anatomy and identify any accessory side vessels that may lead to that non-targeted flow that I was talking about. At this point in the planning angiogram workup, protective embolization may be performed of the extrahepatic vessels. And in this case, we can see gastroduodenal artery and right gastric artery being embolized with coils in the workup angiogram. The radiologists will also look at the tumour feeding vessels and plan exactly where they're going to deliver SIR-spheres. Is it going to be by a single infusion into the common hepatic artery or two separate infusions into the right and left? And once they've made that decision during the angiogram, they infuse technetium MAA at exactly the same sites as they plan to deliver SIR-spheres. MAA particles are macroaggregates of albumin, which is as close as we've got to an imageable surrogate of SIR-spheres. It allows us to get a predictive map of where the SIR-spheres are going to be delivered at the time of the therapy administration. You can see from this image that the particle is quite close in size to the SIR-spheres particle. Once the patient is finished in radiology, they come down to nuclear medicine for whole body imaging to look at the liver-lung shunt, and then SPECT-CT imaging to look at the uptake in liver. The liver-lung shunt is important to calculate because we want to exclude patients in whom there is a significant shunt that may result in a radiation dose to lung of greater than 25 Gray. In this case, there's a very large liver-lung shunt, and SIRT treatment is contraindicated. Shunts ranging between 10 and 20% require a dose reduction. We also look on the MAA study for any extrahepatic localisation of tracer, which may have occurred because of altered flow dynamics from reflux in the circulation down side vessels that's unexpected by the interventional radiology team. We then go on to compare the MAA distribution with the tumour distribution to predict the effectiveness of therapy. We directly correlate MAA with images of tumour. It might be a triple phase CT, an FDG image, or an MRI of liver. And we ask the question, does MAA actually get to the tumour that we want to treat? Are the involved segments perfused and receiving MAA? And if lesions are discrete, is there localisation of MAA within the tumour? This is just a little example of a case that we had. This is an FDG PET-CT, a coronal slice, showing us plenty of disease in the right lobe of the liver and the left. When we saw the MAA study, we could see that there was absolutely no MAA going to segments 5 and 6. A chat with our interventional radiologists resulted in them adjusting the place of the catheter so that we achieved delivery of SIR-spheres to those areas of tumour. Ideally, we have a situation where MAA closely maps tumour and there's greater uptake of MAA within tumour compared to normal liver. A less ideal situation is this one, where we clearly have a discrete area of tumour which is not demonstrating preferential uptake of MAA, and we'd really stop and consider whether we're going to treat this patient with SIRT. The relative uptake of MAA in tumour versus normal liver should be greater than 2 to 1, ideally, and this is generally taken as the lower threshold for safe SIRT therapy. Better uptake in tumour does predict better response to therapy. And where this uptake is poor, as I've said, we need to discuss with the radiologists around the technique of tracer administration, and also consider the dosimetry, the potential dose to the lesion compared to the dose to normal liver, and consider the risk-benefit ratio in this patient. This is just a nice example of where MAA shows you what might happen. A coronal slice again, an FDG image of the liver, plenty disease in the right lobe, and a focus here in the left. The way that the tracer could be delivered by the radiologists resulted good uptake in the right lobe, but this focus here did not receive MAA. On a follow-up image, you can see that the disease in the right lobe responded beautifully. But if we can't get SIR spheres to a site of tumour, we're not going to see response. The next thing to do is to prescribe the dose of SIR spheres to be delivered. Where we commonly start is the modified BSA approach. This is a standard method recommended by the manufacturer, which is based on the patient's height and weight and tumour burden. And we can use this to prescribe for whole liver or part liver treatments. Where we have situations of very discrete disease or a small number of lesions, we can apply two other tools. The first of these I'll mention briefly is the partition model, which is very useful for providing information regarding treatment safety. It involves MERD-type calculations, which incorporate the relative uptake of MAA in tumour and treatment and tumour volumes. It involves setting safe radiation doses for the non-tumour compartment, the lung and non-tumour liver, enable us to consider dose escalation if those are set at reasonable levels. The other technique that we can use is the application of software packages which allow us to create voxel-based dose maps. In our department, we've had access to a package called DosiSoft. This is a French treatment planning platform developed specifically for Y90-CERT to predict the radiation dose to tumour and lesions and non-tumour liver from a particular amount of Y90 SIR therapy. And it involves analysing the MAA uptake in defined areas of tumour. You can see the dose maps laying over the areas of tumour. In this situation, we're proposing a dose of 1.5 gigabecquerels, and we can see from these dose maps the amount of radiation absorbed dose that these lesions are going to receive and the amount to the non-tumour liver. So this is very helpful in helping us determine exactly what dose we want to deliver. The non-tumour liver can take more than that if there's not a significant prior insults, and we could even consider a higher dose to further optimise the dose to lesions. Now, for safe treatment, we need to individualise the prescription for each patient based on the clinical and the imaging workup that we've done. If there are risk factors for RE-ILD, the following strategies can be used. For whole liver treatment, you can apply a 25% dose reduction from the modified BSA calculated dose. Where partition modelling and predictive dosimetry is possible, we prescribe an administered dose that will give a conservative dose to that non-tumour compartment. We might also consider sequential lobar treatments, treating the right lobe and assessing the patient's clinical status, and then the left. We will also consider the possibility of segmental treatments, asking the radiologist, can they get closer to lesion and spare non-tumour liver segments? Sangro from Spain a couple of years ago wrote an excellent paper, and he proposed a simple equation in patients of high risk, which involves administering 0.8 gigabecquerels per treatment liver volume and also administering a prophylactic regime for RE-ILD consisting of ursodeoxycholic acid and prednisone. In a patient who we're concerned about, we will often look at the dose prescription from all of these angles, calculate the modified BSA, apply Sangro's equation, use partition modelling if we can, and to come finally to the dose prescription. So what you really want to achieve in the end is the safe delivery of SIRS that results in disease like this, receiving therapy like that, and resulting in a good partial metabolic response. Now, lastly, I'd just like to describe or have a look at the treatment of metastatic colorectal cancer and the role that SIRT plays. The standard of care for metastatic colorectal cancer involves, I should put first, the resection of oligometastatic disease wherever possible, primarily, then chemotherapy, and then the use of local ablative therapies, which include SIRT. The goal of these local ablative therapies is to eradicate visible metastatic disease and enable the possibility of a disease-free interval, a treatment-free interval that gives the patient a chemo holiday. The choice of the local ablative therapy will be determined by the location and the size and the number of lesions. SIRT has an established role in as salvage treatment in patients with chemo-refractory disease in colorectal cancer. The ESMO guidelines from a couple of years ago describe this quite well. For patients with liver-limited metastases failing other chemotherapeutic options, radioembolization with yttrium-90 resin microspheres has been shown to prolong the time to tumour progression in liver. There's been a recent update of quite a large study which looked at SIRS in this setting, and they also found a favourable survival benefit of using SIRT in salvage therapy. It involved the study of 606 patients with liver metastases not suitable for surgery or ablation, who had progressed or become refractory to chemotherapy at least one line, and in this study they were given up to even 4 lines of therapy. This study found that the median survival times with SIRT were found to be similar to those of patients treated with chemotherapy alone in similar settings. So a line of chemotherapy could potentially, in the salvage setting, be replaced by SIRT, which may well be less morbid for the patient. They also found, importantly, that SIRT treatment was well tolerated, even in the elderly cohort, and the benefit was maintained in patients who received 3 or more lines of therapy. So SIRT as salvage therapy is established. There is evidence of prolonged time to tumour progression in liver and favourable survival benefit in this setting. So it begs the question of whether SIRT can be used earlier, and by improving the control of liver metastases, the dominant site of metastatic disease, impact overall survival. Can SIRT with chemotherapy and biologics be used in first-line therapy? 3 prospective randomised studies have been performed to look directly at this question, and the results have been pooled for combined analysis. It involved the SIRFLOX, Foxfire and Foxfire global studies. And in these 3 studies, it compared SIRT in combination with standard of care chemotherapy to chemotherapy alone in first-line treatment for metastatic colorectal cancer. There were 1,103 patients studied, all with adenocarcinoma of the colon or rectum, in whom liver metastases were not surgically resectable or ablatable. These patients also were allowed to enter the study if they had extrahepatic disease as well, and the primary tumour in situ. Now, the results were unequivocal. The addition of SIRT did not result in improved overall survival, nor did it show any improvement in progression-free survival at any site. Now, at any site means both hepatic metastatic disease and extrahepatic disease. There was, however, a significant delay in disease progression in the liver. For example, in the SIRFOX trial, there was a 7.9-month improvement in the median progression-free survival in liver, a 31% reduction in the risk of disease progression in the liver. The pooled analysis showed a 49% reduced cumulative risk of progression in the liver as the first event. However, liver disease control did not translate to a survival benefit in this whole patient cohort. And this may well be explained, amongst other factors, due to the high proportion of patients who had metastatic disease at extrahepatic sites. Subsequent to the pooled analysis, there's been further analysis of the overall survival within subgroups of that large patient cohort. A strong signal was detected in patients with right-sided primary tumours. And in these patients, there was a significant, the addition of SERT resulted to a significant increase in overall survival, increasing the median survival by 4.9 months. And this is very clinically relevant. The location of the primary tumour in cases of metastatic colorectal disease is emerging as a major prognostic factor and predictor of treatment response. Patients with right-sided tumours, which make up about 1/3 of patients with colon cancer, have worse outcomes and no benefit from EGFR inhibitors. And these are potentially a different disease group genetically. So the discovery that SERT may impact overall survival in this group is a very clinically significant one. So in summary, SERT can be safely delivered and is well tolerated and effective when the appropriate steps are taken with a multidisciplinary and individualised approach to treatment planning. There is no question that SERT is highly active against liver metastases and is a mainstay of treatment of metastatic colorectal cancer for patients who cannot tolerate or no longer respond to chemotherapy. The absence of survival benefit suggests that SERT in combination with first-line chemo cannot be recommended in unselected patients with metastatic colorectal cancer. But based on the preliminary data that we currently have, patients with metastatic colorectal cancer from a right-sided primary could be a clinical subgroup that benefits from SERT in combined first-line therapy. Thank you.
We have a few minutes for some questions. If anyone's got any questions, please.
My name is Hosono from Japan. Thank you very much for your very nice talk. And the vascularity of metastatic tumors in liver are so much various. In some cases, our tumors are substantially hypovascular. So my question is, how often do you experience patients whose tumors are so much hypovascular and in whom you have to give up our yttrium-90 SERT?
You have to give it up. Yes, it's interesting. We certainly see hypovascular lesions, and particularly in colorectal cancer, actually. You know, your typically vascular lesions are neuroendocrine tumour and the primary tumours. Colorectal can be relatively hypovascular. I think we still see good response in these patients, and I think in colorectal cancer, the pathology involves a highly metabolic infiltrative margin into liver parenchyma. And the regional delivery of that radiation can result in a good therapeutic response. And I guess that's why I was trying to illustrate the fact if we can get SERT to the region of tumour, if you've got metastatic disease, widespread metastatic disease, we still may be able to see a good response. If you've got a hypovascular lesion which is just within one segment, what you can consider doing is doing a selective therapy to that segment to do a radiation segmentectomy. So you're basically obliterating that segment. And so it is a complex thing. The MAA may not be ideal, and you need to weigh up many factors when you're thinking about whether SERT is appropriate. Very often we do see regional uptake in tumour, and that's very reassuring. When we don't, as I say, I think we need to stop and think what we're doing.
Our SERT on the basis of some dosimetric approaches?
I'm so sorry, could you just...
Do you use some dosimetric approach?
Yes.
Whether you do or do not to SART?
Yes. I mean, it's difficult where you don't have good uptake in a lesion. I think you need to stop and think whether you treat it all. But if you're able to establish from that partition model or the predictive dosimetry that you're delivering a safe dose to the non-tumour compartment, then you can push up your delivery in the hope to getting a reasonable dose to tumour. Yep.
Thank you very much.
Thank you. We have one more question.
Yes, it's more a little comment. My name is Benning from the Netherlands, from Amsterdam. Thank you for this nice overview, and I know we are in Australia, but I think this was the World Federation conference, and I just want to mention that besides Serospheres, there are other agents. I have no commercial ties, but I think it's nice to mention that the Serospheres have about the same methodology as you described.
Yes.
There are a little difference, there are some differences, but there are multiple vendors who work in the field of CERT.
Indeed, indeed. I didn't cover the glass spheres in the talk today.
We have one more question.
Yeah, Christian External, I'm Nuclear Medicine Fellow in Gold Coast. Is there any data out there comparing ablation, or is there any way to determine whether you do radioablation or microwave ablation compared to cyst?
Yes, it really depends on the lesion location, the size of the lesion. I think there are very specific sizes that the interventional radiologists will consider for microwave ablation. And so where you've got widespread disease, those other ablative therapies aren't an option. Where you've got discrete lesions, this is why I sort of made the point that the multidisciplinary team needs to have a look at those cases involving the IRs and the radiotherapists, because it may well be that you can achieve ablation of segments from SBRT, which is on the rise in our institution. And I think Patrick's going to talk a little bit about the decision tree around using those different radioablative therapies, ablative therapies.
Thank you very much. On behalf of the organisers, we have a certificate of appreciation. Our final speaker for this session, who will elaborate on the topic is Professor Patrick Flayman, who is a nuclear medicine specialist from the Jules Bordet Cancer Institute in Brussels. Please welcome.
Okay, thank you for your kind introduction. I'm happy to be here, and I want to thank the organizers to have invited me to come here to Melbourne. My lecture will deal with two important aspects of the management of colorectal liver metastasis. The first part will deal with the work that is performed with FDG PET-CT for the preoperative workup of liver metastasis. A lot of recent data have come in on the use of PET for prognostic stratification and also for early metabolic response assessment. And the second part of my lecture, I will discuss more personalized ways of performing the radioembolization in colorectal cancer metastasis. As has been said already by the first lecture, this is the majority of liver metastases of colorectal cancer origin are not resectable initially. So the aim of oncology is to get those non-resectable liver metastases to resection. And so the role of PET in this basic diagram of management of liver metastasis is first to detect non-resectable disease, and secondly to be able to to choose the most optimal active therapy in order to get non-resectable disease up to resection. If you look at the list of prognostic factors which are known in colorectal cancer, liver metastasis, you see that a lot of them deal with extent of disease. You have the tumor marker, the number of lesions, the size of lesions. Then we have a second important factor is the presence of extrahepatic disease. And the third factor is the grade of disease. And you have to understand that most of these prognostic factors can be directly or indirectly measured by FDG PET-CT. And this is the basis of the most important prognostic value of FDG PET-CT in these patients. So I will not go in details of the extensive literature on the use of FDG PET for colorectal liver metastasis staging, and I will limit this overview on that subject by this very nice meta-analysis published in the European Journal, meta-analyzing 18 studies on this subject, including more than 1,000 patients. And the conclusions, I think, are still very valid. First conclusion is that PET for liver detection of liver lesions on a lesion base has a lower sensitivity than MRI and CT. Here the PET value is a bit low, but this is because the meta-analysis also included data from older studies where PET was even not PET was a standalone and not PET-CT. The major thing that we have to keep in our head is that we are more specific than MRI and mostly than CT. So we have maybe a lowest lesion sensitivity but a higher specificity. The mainstay, the major technique in the assessment of liver disease is MRI, which has a high accuracy. PET comes in the detection of extrahepatic disease. In this meta-analysis, about 32% of the patients which were upfront considered for resection had to be excluded for surgery based upon the presence of extrahepatic disease. And PET findings changes the management in about 24% of the patient. A very nice prospective data set. There are not so many prospective randomized trials testing diagnostic tools, but this is one of the very nice examples where PET-CT was together with CT compared to CT alone in the workup and the preoperative workup for colorectal liver metastasis. It was in a prospective randomized trial in 150 patients, and the endpoint was the number of futile laparotomies. And it was found that if you add the PET to your preoperative workup, to CT, you have a significant decrease of 38% of the number of futile laparotomies, going from 45 to 28% of the patients. So in other words, PET prevents unnecessary surgery in 1 of 6 patients, and it has also an impact on the disease-free survival. As you can see in the table in the middle, the most important impact of the adding PET to the preoperative work came from the detection of unsuspected extrahepatic disease. So far, so good. This is well known, and FDG PET-CT has been accepted in most worldwide guidelines in the preoperative workup of liver metastasis before major surgery. What is less known is the prognostic value of FDG uptake as such in the lesions. And more and more work is ongoing on this intrinsic prognostic value of the FDG uptake, not only in colorectal cancer, but also in a lot of other tumors. And here is the first or an important primary paper on this work, which assessed in 245 patients the intensity of FDG accumulation in liver metastasis and correlated that with outcome. And you see a very significant correlation with disease-free survival, with patients having intense uptake of the liver metastasis having a significantly better disease-free survival compared to the low uptake. Classically, if we speak about high or low uptake, we use what is called the persist-like cutoff, which is 2 times the normal liver parenchyma uptake, which is about 4 or 5 SUV. So together with the intensity, also the tumor load is important, and this is a covariable, it's an independent covariable, and as also has been shown in this article, we have 4 categories of patients. We have the low tumor load, the low tumor load, low SUV uptake ratios, which have the best prognosis of about 50% long-time disease-free survival, versus the high tumor load with high SUV ratio, which have a very bad short-term prognosis. So more and more data are getting available in oncology in general on the value, as I said, and prognostic value of the total metabolic tumor volume, which can very well be assessed by a whole body FDG PET-CT. Major papers have come out on lymphoma of the French group, and here you see some examples where there was a very good correlation between the baseline tumor load, the correlation between baseline tumor load and outcome of these patients. Tumor load can now be rather easily calculated using modern software packages which perform automatic segmentation of tumors. And as you can see from A to D, you have an increasing metabolic active tumor volume. This has preliminary data have come out from lymphoma, but also from other digestive oncology. And we tested whether this was also valuable for metastatic colorectal cancer. We performed a big prospective trial with this as one of the the secondary endpoint. And as you can see here on this Kaplan-Meier curve, in these 141 patients with non-resectable liver metastatic disease with or without extrahepatic disease, and these patients were treated with regorafenib as a second-line or third-line treatment, we see that the overall survival was dramatically different according to high versus low tumor load. You see that the median overall survival in high tumor load is 11 months compared to 4 months overall survival in low tumor load. This is very important prognostic information, which is until now not very used by the oncologists, because if you don't have PET, it is very difficult to calculate these tumor volumes. So we are not alone on the field of prognostic biomarkers, of course. We also have the non-imaging circulating biomarkers, and something that comes up at a high speed now is the circulating cell-free DNA. So we have at the right side the TMTV and its relationship to prognosis in metastatic colorectal cancer. And now I show you the cfDNA curves, which are almost similar. And this is a kind of a cross-validation, let's say, of both techniques, and as being both very determinant for outcome of these patients. And cfDNA, as you can see upper right, is very correlated with MTV. So both are indicators and for the tumor load at baseline. So what about response? So we know that tumor load is important. Does response add something? It's an important question. We never looked at that really. We know, and I don't go in detail, I don't have the time for that, but metabolic response is more rapid, it's more sensitive than the shrinkage of the tumor, as assessed by morphologic imaging techniques. As it is more sensitive, we can do it more earlier. And we are doing this more and more, even in routine clinical oncological practice. We're doing early FDG PET-CT scan. Instead of doing them together with the morphologic imaging at 2 months after initiating therapy, we do that after 1 cycle. 1 cycle, 2 weeks, 3 weeks, so that we have a rapid prediction of response. And this is very important if you go back to my first slide, where you want to downstage unresectable liver disease to a resectable liver disease stage, and you should be sure that you don't waste time with treating patients with ineffective treatment. So we have to assess very quickly whether a drug in that condition is effective or not. And we have published a lot of papers on that, which indicates that the negative predictive value of early PET scan is very high. If you do a PET scan at 2 weeks and does not show any metabolic response, then the probability of having a late response, or probability of having a tumor shrinkage is very little. And this is, of course, a very nice tool to perform personalized treatment, rapid treatment adaptation. A third thing which is very important is that the heterogeneity, it's a very trendy word now. PET allows to assess heterogeneity in response. As we are able to assess all lesions in one examination at the same time, we see a lot of treatment response heterogeneity. Response is not a yes or no if you consider a number of lesions. It is a heterogeneous in 1/3 of the cases, and the prognosis of the patient is defined by the non-responding lesion. So, this is an example published by our group of early response treated in patients with second, third line, sorafenib, capecitabine, and you see the baseline PET, then the early PET scan, you see that the signal in that necrotic liver metastasis is not declining, there is a metabolic stable evolution, and then in this trial, of course, we performed systematic late PETs, and you don't see any further response. We correlated early with late response, and the negative predictive value of an early non-response is very high, 95%. So that means that you can perform a rapid treatment adaptation, and these kind of images are nowadays regularly seen, because oncologists did take up this idea about rapid treatment change in order to avoid treating patients for a longer time with ineffective drugs, which is really a problem in oncology today. You can see here an example. We treat at baseline 2 liver metastases. At early PET scan, you see the dates there. 2 weeks after the baseline, you see that there is no response, no significant decrease of FDG. We changed the oncologist in a multidisciplinary team decided to change, and they went from FOLFOX to FOLFIRINOX and added Avastin. Then you see a metabolic response. So you have treatment. This technique, early response assessment, allows rapid treatment adaptation. So we did a lot of work on that early response, and we have a multicentric trial set up in Belgium where we perform baseline and PET, and then PET at 2 weeks in these chemorefractory patients. And this is about the trial which more than 200 patients were included in this phase 2 trial. The first thing that we saw is that we are major. If you want to perform treatment adaptation based on response PET, then you have to look not to response, but you have to look to non-response. And for detecting non-response, you have to look for stable, metabolically stable disease. So you have to lower the classic PERSIST cutoff of 30% to 15%. As can be seen here in this big patient subset, the PERSIST 30% response did not correlate to PFS, while the PERSIST 15% did well. So this is important to retain. Thus, what about the relationship between that metabolic response and the metabolic tumor volume? In fact, multivariate analysis indicated that these two variables are independent. So that means that we can identify 4 classes. We have this the best class, it's a low metabolic tumor volume with a good response, PERSIST 15% response, and the baddest class is the high metabolic tumor volume with non-responding. You can also see that the benefit from chemotherapy in that case it was regorafenib, that the benefit is mostly seen in patients with low tumor volumes. These are the upper 2 graphs, whereas in the high liver tumor volumes, we see very little effect of chemotherapy, and that's something that we are trying to get more and more implemented in the oncological workup of, and follow-up of these patients. This, we are not the only one, of course, that find this and defend this. Other centers that find the same. They work with TLG, which is the product of the SUV intensity and the volume, and they found also that the TLG baseline as well as the TLG response are both correlating, are both predictive for patient outcome. So that was the first part. The second part is about the multimodality imaging and CERT, and I'm happy that I can speak after the excellent previous speaker who did an excellent introduction of CERT and indicated that when we use CERT as indicated by the manufacturer, that we are not, that it's not clear whether we are helping patients. So we should look for other techniques to optimize this treatment. And we have a lot of fantastic techniques in our hands in molecular imaging. We have, of course, the PETs, the FDG PET to indicate the target volume, metabolic active target volume, and then we have the mebrofenin SPECT-CT who came up from disappearance. It's an old technique which was used before to detect cholecystitis, etc., but which was not useful anymore. And now we took it up because it is a good indicator for local regional, for the whole liver and local regional liver function distribution. Then we have the simulation with MA SPECT-CT, and then we have the Y90 PET-CT imaging, which is performed after treatment. With all this information, we can do a lot of things. And we can do more than that. This was a very depressing result. The whole commercial world went into, in radioimmunization, went into depression because it was an enormous financial misadventure resulting in this negative Foxfire, which has been already explained by the previous speaker. How comes? And I think you don't have to look very long to these images. These images are given to me by Dr. Lam. And you see these patients have been included in this in colorectal cancer trial. These patients have two different livers. You see a small liver with a small tumor involvement, and then the other at the right side, you have a very large liver with a high tumor liver involvement. And you see that these patients, according to the formula that was provided for the investigators in the SURFLUX trial, which was essentially very simple, BSA, the body surface area normalized, these two patients received the same dose, which is, of course, absurd. One patient at the left, he went to REALD because we gave too much dose in a too small liver, and the other treatment was ineffective. The patient went to early progression because, of course, the amount of activity in such a big liver is not sufficient enough. So we have to go to personalized dosimetry. I think now we are getting more and more sure about that. We have to indicate to know where are we in terms of therapeutic window. Therapeutic window is defined by the dose, by the dose effect curve, the blue curve, and also by the toxic curve. And so we have to treat somewhere within that therapeutic window. But how we know this therapeutic window? The first thing that we have to assess is whether there is a correlation between the dose or the activity that we give and the therapeutic efficiency. And the second thing that we have to check is, do we have an idea about the relationship between dose and toxicity? And I will discuss both items separately. First, the efficacy. We have an excellent technique now to assess, to measure quantitatively exactly the dose that we gave after CERT. We can perform the Y90 PET-CT, as you know, Y90 is also very weak, but some positrons are emitted by Y90, and we can do positron emission tomography. And then you can transform this. The physicists are working on that. They can transform these images to parametric images, and then they can make isodoses, as you are used to see with radiotherapy. And then these isodoses are projected on the target volume, which is the baseline FDG PET-CT. And what we did is to see what the correlation between the real dose that we gave to the tumor and the effect measured by metabolic imaging, which is the most efficient way of assessing the effect of radioembolization. And we came up with these curves. These curves has also been produced by our colleagues in Sydney, where you see that there is a rather nice dose effect correlation. And as you can see, if you want to have a significant effect, which we then you have to increase the dose if you want to have an effect of TLG decrease of more than 50%, which is generally considered as a good sign of response. We have to increase dose up until 80 or 100 grays at a lesion level. Of course, we don't have, unfortunately, the Y90 PET image before we start to treat, so the only thing we have is the MAA spec. I know that several investigators have killed the MAA, but I'm a big defender of it. At least MAA, good simulation, it gives you exactly the volume that you will treat, and that's already a starting point, and it provides you also an idea about the hypervascularization of lesion, which is a very important predictive biomarker for treatment response. And we 10 years ago, I think, in the meantime, we correlated these MAA uptake with, or the dose calculated based on the MAA spec with effect, and we have similar curves. So based upon MAA, we can do these, estimations of the dose that per millicurie injected will be given to a time point. A second major aspect of that personalizing of the dosing is having an idea about the toxic effect. Is there a dose toxicity correlation? We do not know exactly. We expect yes, of course. And how can we measure? And this is what I discussed already, the old technique which came up again, which is the mibrophenine technetium labeled SPECT-CT technique, where we can assess liver function, and it's a very simple technique. You can implement it very easily. You inject and you do a dynamic image based upon this dynamic image wherein is the liver and the heart. You can calculate the percent uptake of the tracer at the liver percent per minute and normalized per BSA and work. And then after this dynamic acquisition, which it takes about 6 minutes, we perform a SPECT-CT immediately after the planar acquisition dynamic, and this gives you, in fact, this provides you the regional distribution of the whole liver function that you measured on your planar dynamic phase. So extensive work of the Dutch people of the Graaf and Roel Benning, who is here apparently, indicated that they found out that using this technique, the 2.7% per milliliter per square meter is about the minimal function that you will have, that you need to have a viable liver function. And so we can intellectually, we can use this cutoff. I know that some people say that we still can lower this cutoff, but I'm a bit conservative and we use the 2.7% as a cutoff for viability. So what we do is we assess the function of the liver. This patient, for example, has 4.4%. Normal values are 6, 7, 8. And we knowing that the lower limit of viability is 2.7, that you can easily calculate that the hepatic functional reserve is 38%. That means that with your treatment you can lose 38%. If you go beyond the 38% damage, then you will risk to have a complication in these patients. So what that is the work that we are doing actually. So based upon the MAA, we are generating these isodoses with software packages the same as the previous speaker uses, the Dosisoft package. We can get these isodoses, then we project these isodoses of the MAA on the FDG PET-CT to know whether my target volume is really covered. And secondly, we project that also on the SPECT-CT of mibrafenine. And so we can have an idea about the amount of parenchyma which will be touched, which will be irradiated by your radioembolization. And for example, in this patient, as you can see, because the tumor, of course, it's non-functional, it does not take up the mibrafenine, does not participate to the overall liver function. So we can, in this case, of course, it's clear that whatever dose we give, whatever activity we inject, it will never damage the liver function because the isodoses are retained within the cold spot. And so that means that we can, in these patients, go to ablative techniques. We are, which are techniques injecting much higher dose than would have been prescribed by BSA. Anyway, since the negative trial, we stopped comparing to the BSA because it's an absurd comparison. Now we do these volume-based dosimetry approaches. In conclusion, the molecular imaging are very useful techniques for management of colorectal cancer liver metastases, both in the preoperative diagnosis and workup. Important new information is coming on about the MTV, and it goes in parallel with the MTV papers are published in lymphoma. We have tools for rapid assessment of treatment efficacy, which is important if you want to downstage patient from inoperable to operable or non-resectable to resectable disease. And then we have tools also to personalize certain dosimetry based upon dose-response relationship, which has been proven now, and possibility of assessing functional liver reserve with mibrafenine. Thank you very much.
Are there any questions from the audience?
Thank you, Professor Flamen, for this comprehensive talk. Actually, I would like to ask regarding the role of FDG PET-CT or the finding in post-surgical setting of the liver metastasis. Post-surgical setting, also post-CERT treatment. Sometimes we encounter the situation of having this inflammatory activity in the surgical bed or around the previous liver metastasis. How do you deal with this issue, please?
Yeah, we have to be very careful in these post-interventional PET scans. The classic, you risk to have false positives. Most of these false positives are at where the resection has been performed, and there can be some granulomas there that take up very intensively. It's impossible to differentiate that from residual tumor versus these granuloma which take up very FDG. Normally, after resection, we wait 2 months. But these granuloma can still be very active until months later. So, but if you're aware of the existence of this, you can take into account that. For radiofrequency ablation, for example, it's a different setting. There, if you are interested to know whether you have hit the whole liver, you should do the PET scan very early, even after some days, because the effect of radiofrequency ablation is immediate. You have an immediate elimination of metabolism. If you do it later, then you have problems with edema, etc. So the dynamics of the follow-up PET scans depend a bit on the treatment that you want to test.
In case of encountering such a granuloma, is there a recommended time frame to follow up the PET-CT? Is there?
No, I have granulomas that stayed active during months, so I don't have any time. I think you do there kind of it's even with correlative imaging, MRI, CT, PET, you cannot really differentiate these granulomas from residual tumors. So we are stuck.
Thank you. Thank you.
Any more questions? Well, in case there are none, thank you, Professor Fleming.